So greetings everyone once again and welcome to the 72nd session of the online Optom Learning Series or OOLS. Let me introduce to you all our speaker for today. So today we have Optom Sweta Ravichandran. She is an optometrist who completed her bachelor's of optometry from the Elite School of Optometry, Chennai, India. And currently she is pursuing her master's from the Manipal University. Her specialty interests are in anterior segment conditions, contact lenses, dry eye, and meibomian gland dysfunction. And today, Sweta is going to talk to us about how we can use anterior segment OCT in diagnosing certain ocular conditions. So, welcome Sweta onto our platform.
Thank
Thank
you,
you
sir.
so much for most welcome for taking out this time. And let me just leave the screen time to you now.
Thank you so much for that introduction, sir. And yeah, without further delay, I'll go into the presentation. So we are basically going to talk about the application of AS-OCT in diagnosing various ocular conditions. So anterior segment OCT is used for a variety of purposes, and discussing about that is a very long topic. So I'm going to restrict myself and talk about a few general things that we can diagnose by using AS-OCT, and I'll basically talk about cornea, conjunctiva, and also some of the glaucoma diagnostic procedures. So these are the contents which I'll be covering basically. So I'll talk a little bit about the introduction. I'll move on to the imaging modes that are available in AS-OCT. I'll talk about the advantage over UBM and also talk about corneal, conjunctival, and glaucoma diagnostics. So moving on to the introduction. So you must be knowing that ocular coherence tomography is used for both anterior and posterior segment, but it was first developed by Huang et al. And he was the one who developed this. And it is basically a non-contact imaging technology which is used for creating cross-sectional images of the biological tissues. So specifically, anterior segment OCT was introduced in 1994, and it is used for imaging the cornea, conjunctiva, sclera, anterior chamber, and various other anterior segment structures. So before we move on to the other things, I think we should get to know about the principle of AS-OCT specifically. So we have a light source which is going to be coherent, and this gets split by the beam splitter, which reaches the reference mirror, and one of it reaches the sample. So I is our sample, so that is going to reach the sample one, and the other one is going to go to the reference mirror. So we will actually receive waves from both the sides, and OCT will actually compare the time delay and the intensity of the infrared light which is being used. So there's going to be reflected infrared light from both these sides, which will be combined against the reference beam, that is the one which is coming from the measurement beam, that is from the eye, will be compared against the reference mirror, and it will be giving us a value, or the detector will give us the final output. So this is basically in time domain OCT. So there is also another one which is also called the spectral domain or the Fourier domain OCT, where you again have a low coherence light source which gets lit up to the reference mirror and the sample, but there is a diffraction grating, and there is a spectrum which is being produced, which will be analyzed by a spectrometer in order to detect the final output. So you will be able to get the output in terms of path difference, and you will be able to see the AS-OCT image in the end. So basically, there are various A scans which are initially taken, which is actually the depth profile which is present in the eye at different locations. So after combining an array of A scans, we will be able to get a B scan. So this is actually an image of the posterior segment OCT. So you can see there are various A scan located at taken at various lateral locations, and these are actually combined to give us a B scan. So this B scan is actually one B scan. In case of a total image, there will be multiple B scans also combined to give us the output image. So I'll just compare between the two different types of OCT which are available. The first one being time domain OCT, as I already mentioned. It is a first form, and it is using a reference mirror which can be moved or varied, and it also compares the time delay and the intensity of the infrared light. Some examples for the time domain OCT involve Visante OCT and the Heidelberg slit lamp OCT. They basically use a wavelength of 1310 or 10 nanometers, which is actually going to reduce the scattering effect, and there is less amount of signal loss. And apart from that, there is a large scan width, which is about 16 mm, and the scan depth is about 6 mm. Coming on to resolution, there is about 18 micrometers axial resolution and 16 micrometers along the lateral plane. So when you see spectral domain OCT, the reference mirror is going to be stationary, but there is a spectrometer which is used for analyzing the spectrum which is obtained. So examples for this type include the spectralis OCT and the cirrus OCT. The wavelength which is used in this type of OCT is 830 nanometer, and the scan width is actually reduced to around 3 to 6 mm, and the scan depth is also reduced than the time domain OCT. But the resolution in case of a spectral domain OCT is going to be comparatively more than that of the time domain OCT. By looking at the numbers, we see this is less than this, but it's actually not that. When you say resolution, it means you are able to distinguish two separate structure as separate. uh, that is how you define resolution. So when the values are lesser, that means even structures which are 4 micrometers apart can be distinguished as separate structures in case of a spectral domain OCT, and in case of a time domain, it is more only when the difference or the distance between two structures is going to be 18 micrometers. Only then it is visible for us as a separate structure. So axial resolution is along the this direction, and lateral resolution is along this direction. So I just wanted to show you that. So I just used this image for that. So here we have Visante OCT. This is how the Visante OCT would look like. And next we have step source OCT, which is SS-OCT. And this is another form of spectral domain OCT, which uses a wavelength of 1310 nanometers. And Cassia OCT is an example for this type. Here the scan width is about 16 mm and the axial resolution is around 10 micrometers. Ultra high resolution OCT is a very good high resolution producing OCT type, and you can see that the resolution is very high in this, around 1 to 4 micrometers, but the scan width is also around 5 to 12 mm, which is a little comparatively lesser than the time domain. And the examples for this type is the Bioptogen and the Copernicus HR OCT. And this axial resolution, which is very high, is actually obtained through the light source which is used. So this light source which is actually used has a broad bandwidth of about 100 micrometers, due to which there is a large amount of resolution which is being produced. So this is an image of a Cassia OCT. So now moving on to the various imaging modes that are available in an OCT. The first one is a high resolution cornea single. So this can be obtained at a particular resolution and at a particular location. And in case of a cornea quadrant, this images will be taken at 4 different quadrants. So like you will have the first image to be between 0 to 180 degrees, the next one to be 45 to 25 degrees, and the other ones follow like that. So the next one is going to be pachymetry. An AS-OCT image also gives us sheen plug images and also pachymetry for measuring the corneal thickness. And you also have an anterior segment single, double, and quadrant respectively. Supposing you're going to rotate the angle at which it is particularly taken, the other angles that follow would also change by the same amount. So if I'm going to start with 10 degree, then the other degrees that would follow will also be changed by that amount. So let's begin the diagnosis and images with a normal OCT image. So this is how a normal AS-OCT image would look like. So if you can see, there is a certain amount of reflectivity which is found in the corneal location. But if you look at the limbus and the conjunctival locations, it is a little higher reflectivity. This is comparatively of higher reflectivity than that of the cornea. So this is how you explain reflectivity, like based on the grayscale, you would be explaining the reflectivity based on that. So this is how a normal reflective cornea should look like. So this is just to show you the various layers. It would not be exactly possible to delineate between the layers and say this is the epithelium, but you would be able to see the most of the cornea is occupied by the stroma, so which occupies the center location, and the lower portion would involve the endothelium and the Descemet membrane, and towards the anterior or the towards the top portion, you will have the epithelium and the and the Bowman's membrane. So now moving on to the differences between UBM and OCT. So ultrasound biomicroscopy has a resolution of actually 20 microns axially, and it is about 50 microns laterally. So this is actually comparatively lesser than any type of OCT which can be done. So, but it has also has an advantage that it is capable of visualizing the ciliary body and the retroiridal structures very clearly. And apart from that, it is the gold standard technique for making a diagnosis for plateau iris configuration, and also to look at the various retroiridal processes which are present there. So this is one advantage which is present in UVM. But if you look at OCT, it is very easy and rapid. There is no contact. It is very repeatable, and there is a high resolution which can be obtained, and it is done at a seating position. But if you look at UBM, the patient has to lie down in a supine position, and there could be possible corneal compression. Apart from that, the patient would experience discomfort. There could be abrasions or infection post procedure, and it is really time consuming, and you will also require a trained operator in order to perform UBM. But your OCT is very simple, and it can be done very quickly, and it is very easy to be done at a seated position. So now we are moving on to the main part of our lecture, which is diagnostics. So in case of cornea, apart from whatever I have mentioned, it is possible to even diagnose other things in case of cornea. So basically, it is very helpful in diagnosing corneal scars, keratopathy, and to analyze the cornea pre and post lamellar transplantation procedures in order to look at keratoconus keratoconus. In case of keratoconus, you can look at acute hydrops. And when you're treating keratoconus with Intex, even that can be visualized by using AS-OCT. So you also have refractive surgeries which are done and would be analyzed by using AS-OCT. And you also have keratoprosthesis and other pathological conditions which can be visualized by OCT. So the first thing here is actually the scar. So remember the image that I showed you in the beginning, which is the normal reflectivity of the cornea. As you can see, there is very high reflectivity in this image. There is a high stromal reflectivity at the location of the scar, and there is also associated increased thickness as well. So, in case of a cornea which is having a scar, it is not very feasible to look at the corneal thickness properly. So, in that condition, scar depth can also be measured, and also the accurate central corneal thickness could also be measured by using an AS-OCT technique. So, in case of a scar, AS-OCT is used for such purposes. So, now we have reached to the first pole. So, the question is, what is a type of keratoplasty procedure that you would prefer in case of endothelial dystrophies? You can choose whichever is possible, like even multiple ones, whichever can be used, you can go ahead and click that.
Yeah, the results. So majority, Sweta, majority of them think penetrating keratoplasty would be the option, almost 50%,
Okay.
and followed by Descemet's membrane endothelial keratoplasty, which is 42%,
Mm-hmm.
and then 12 and 29% of them think DALK and DSEC respectively. So that's the kind of response we have.
Yeah, so I think most of you have preferred the right one. Like penetrating keratoplasty can be used in case of endothelial dystrophies. You can go ahead with DSEC and DMEC as well. But DALK is not the type of keratoplasty technique which is used in case of endothelial dystrophies, because as the name suggests, it is anterior, so it is not going to treat the endothelium. As you must be knowing, endothelium is present in the posterior location, so it's not going to treat the anterior, it's not going to treat the posterior dystrophy which is actually present. That was good. So let's move on to the next slide. So here, I just wanted to tell you how dystrophy would look like, specifically Fuchs dystrophy would look like in an AS-OCT image. So if you look at the image, you can see that there is some increased reflectivity along the endothelium. So these are actually the catheta, which is present, indicated by the number 1, which is here. So these are the catheta, which is actually present in case of Fuchs dystrophy. These are not very prominent, but if you would look at a slit lamp, I think it would be more clear to look at a catheta in a slit lamp than in an AS-OCT. And you also have some intrastromal fluid which is present. So here you have the small locations which appears as a gap. So these are actually intrastromal fluids which are present in case of dystrophy cornea. Next, we have thickened Descemet's membrane, which is also a sign which could be present in case of a dystrophy. And you also have bullae when, in fact, when there is also bullous keratopathy associated with the dystrophy, you might end up seeing many epithelial bullae along with the other signs that you would be seeing in a cornea. So you can also see the bullae which is present between the epithelium and the Bowman's membrane. So next, I'll give you an overview about the various corneal grafts which are present. So basically, the first one, penetrating keratoplasty, is the most preferred one for replacing the entire cornea. So in this procedure, you have the entire corneal layers which are replaced by the donor cornea. So here you can see the PK graft is involving the pink portion, which is actually involving the entire cornea. If you look at deep anterior lamellar keratoplasty, this is actually preferred for most of the condition that does not involve the corneal endothelium. So DALK will actually allow the replacement of the deceased recipient stroma with that of a donor stroma. So when this transfer is done, the Descemet membrane and the endothelium will be retained as it is. So you will have the epithelium, Bowman's membrane, and the stroma to be replaced with a donor cornea. In case of a DSAEK, which is the Descemet stripping endothelial keratoplasty or Descemet stripping automated endothelial keratoplasty, you will have the Descemet membrane and the endothelium being replaced by a portion of uh, cornea, which involves a certain amount of the posterior stroma and the Descemet membrane and the endothelium. But if you look at Descemet membrane endothelial keratoplasty, it involves the transplantation only of the Descemet membrane and the endothelium. So the donor cornea tissue is the difference between DSAEK and the DMEK graft. So in DSAEK graft, you have the graft portion which involves three structures. That is the posterior stroma, some amount of posterior stroma, the Descemet membrane and the endothelium. But in case of a DMEK, you only have the Descemet membrane and the endothelium, which is present in the donor cornea. So these are the various grafts which could be performed. So talking about the role of AS-OCT in these techniques, in case of a deep anterior lamellar keratoplastic procedure, you can actually look at the various appositions. Like when I say apposition, it means whether the graft and the host is attached and whether there is any DM detachment, or whether there is any thickness or in the donor or the host could be analyzed by using an AS-OCT technique. So if you can look at this, it actually represents the graft and the host thickness. So you have the graft, which is in the anterior portion, and you have the host, which is in the posterior portion. So here you have 410 and 80, which is the graft and the host thickness respectively. Now moving on to Descemet stripping endothelial keratoplasty, as you can see, there is a difference, like it is not properly aligned with the cornea. So as I told, there is some amount of posterior stroma as well, which is involved in the graft. So that is why there is some difference when you look at the structure as such. So in case of a Descemet stripping endothelial keratoplasty, we can look at the graft dislocation, or when there is a graft failure, we will be able to look at it by using an AS-OCT technique. So I will be showing a picture which shows the graft failure in the upcoming slide. So it is basically used for that purpose. And sometimes even DM detachment in case of Descemet stripping endothelial keratoplasty can also be visualized by using AS-OCT. So here you have Descemet membrane detachment. So this, which is shown here, is actually the Descemet membrane detachment, which can be visualized by AS-OCT technique. Sometimes when there is no stromal edema, or when there is the cornea is not clear, you will not be able to visualize this through a slit lamp, basically. So you will need to look at an AS-OCT image in order to look at the Descemet membrane detachment, which is present. So in case of looking at the grafts, and in case of looking at the various keratoplasty techniques, these are the various signs or diagnosis that you can make using an AS-OCT technique. So as I already mentioned, you will be able to see the rejection or the graft which is not accepted by using the AS-OCT technique. If you can look at this, there is a perfect delineation between this the graft and the host. If you can see, this is actually the graft. This is a DACK graft, and this is the host cornea, but it is not actually accepted. It has been rejected, so that is why it is separate. So you will also be able to visualize this by using an AS-OCT technique. So next we are moving on to various other signs which could be seen by using an OCT technique. So the first thing is in case of bullae keratopathy, corneal bullae is a very classical sign that you would be able to see. So the bullae would be present between the epithelium and the Bowman's membrane, and this would be actually visible as small non-reflective portions, which is visible here. So these are actually the bullae. And there is also DM folds. DM folds will actually appear as wrinkles in the DM layer. So as you can see, there is some wrinkle which is present in the structure of the posterior cornea. So this is actually representing the DM folds which is present in the cornea. Now sometimes there might be even an interstitial space which is filled with some intrastromal fluid. So, in order to recognize that as well, you would be preferring to look at a AS-OCT image sometimes. So here you have different measurements which are made. So you can also measure how much amount of intrastromal fluid, how much of the cornea is filled with that fluid, and look at that as well. Now we have come to the second pole. So the basic question here is what you actually see in this image. So you can start giving your answers. Sir, you can launch the poll. So whether it is corneal collagen cross-linking, or corneal ring segments, or keratoprosthesis, or Osteo-Odonto-Keratoprosthesis.
About 65% of people think that it is intrastromal corneal ring segment. Add on one because somebody did reply on the chat as well, the same answer. And 15% of them think it's corneal cross-linking, 17% of them think it's keratoprosthesis, and just 3% of them think it's OOKP.
Okay. So that's nice. I can see everyone participating, and yeah, keep sending your votes so that it would be interactive and you can also get benefited by that. So from these answers, it's very obvious that intrastomal corneal ring segments is the answer. It's not corneal collagen cross-linking because it's not going to involve any rings which are going to be placed in the cornea, and it's not keratoprosthesis as well. I will be showing images of keratoprosthesis in the upcoming slides, so you can look at how it looks exactly. So yeah. So I will talk about Intax now. So basically, Intax is preferred as a treatment modality for keratoconus, periostid marginal degeneration, and also for post-elastic ectasia. So if you see, there are two crescent-shaped pieces which are placed here. These are actually going to be made out of PMMA material, and this is actually going to flatten the cornea in case of an ectatic cornea like that of keratoconus in the steep portion. So it is going to flatten the cornea and reduce the steep portion, and it also reduces the visual distortion which the patient would be experiencing due to the increased steepness of the cornea. So if you have to think what is the use of AS-OCT in Intact, so it is basically inserted at a particular depth. That insertion depth has to be actually maintained at a distance of 66 to 75 of the total corneal thickness. So it has to be placed at that particular insertion depth. So that can be actually visualized by using AS-OCT. So as you can see, they have measured at what location. This is actually the Intact. So this is going to be represented as a non-reflective portion on either sides. So since it is a cross-sectional image, you can actually guess that the non-reflective portion here could be the Intact, which is actually placed on the peripheral location of the cornea. So they have used to measure the insertion depth of these Intacts by using AS-OCT. So that's the important use of AS-OCT in case of Intacts. Next, we are moving on to acute corneal hydrops, which is a very classic sign of advanced keratoconus. So here, what exactly happens is in case of ectatic conditions, since there is some disruption in the Descemet's membrane, there happens a certain leakage of fluid from the aqueous into the corneal stroma. So that leads to stromal edema as well. So this AS-OCT technique is used for determining the corneal thickness, or when there is any depth of DM detachment. If there is any DM detachment, you can analyze the depth. And if there are any DM breaks, it could also be visualized by using AS-OCT technique. Since there is not proper visualization by using a slit lamp technique, AS-OCT would provide a very useful way for analyzing all of this in the images. So this is how it would look in case of an acute corneal hydrops. The cornea will be completely disrupted. So here you can see a hyper reflectivity. So this is a location where the acute corneal hydrops and the scarred cornea is actually located. If you can think like when there is an hyper reflectivity, there could be a scar as well. Since I have not shown the correlating clinical image, we can actually guess that this is actually associated with a scar, which could occur when the acute corneal hydrops is not treated as such. And this is how it actually looks in an AS-OCT image. Next, we are moving on to ulcer, or you can say generally as corneal opacities. So, corneal opacities in case of any keratitis, or when there is any chemical burn, or if there is any foreign body, or if there is any corneal ulcer as well, there will be a specific or a sharp interface between the opaque cornea and the normal cornea. So, if you can see, there is a opaque cornea which is very hyper reflective, and there is a normal cornea which assumes the normal stromal reflectivity. So that is there is a sharp interface between the two. So this is how you actually recognize that there is some delineation. But if you have to specifically just look at an AS-OCT image and say this is an ulcer or this is a keratitis, it's not possible. You have to correlate with the clinical picture and make a differential diagnosis as to what it exactly is. But apart from that, if you also look at these images, you can do measurements for the treatment, like for treating these opacities. Phototherapeutic keratectomy is the usual management procedure that they would do. So for these procedures, it's necessary to know the depth of that opacity and how much it has to be treated. So for that purpose as well, AS-OCT would give you the accurate depth and the accurate amount of microns which are involved in the um, lesion as such. So this again is the image of an ulcer where measurements are actually made. So the top portion actually shows the exact ulcer, and the lower portion is actually looking a little hyper reflective, but it is actually normal. So so this portion is actually the ulcer which has to be treated or surgically treated with whatever technique is possible. So next we have LASIK. So there is a important thing that we have to consider when we are treating a patient with LASIK. So I will talk more about LASIK in the upcoming slides, but here exactly what they are measuring is the LASIK flap. So there is a certain amount of thickness that has to be maintained when you perform the LASIK, and post LASIK there is a certain amount of stromal bed that has to be maintained. So you have criteria that the stromal bed has to be somewhat thicker compared to that of the flap. So the flap thickness has to be ideally maintained as 100 microns. So in this, when there is a thinner flaps and there is a thicker stromal bed, there is an decreased incidence of post-LASIK ectasia. So that is the purpose why these two has to be measured post LASIK. But even thin flaps, very thin flaps, can also end up with complications like buttonhole or any lacerated or even displaced flaps. These flaps are actually supposed to be centered. So they have to be very centered and they have to be very uh, ideally looking a little hyper reflective compared to the other location of the cornea. So it has to be uniform as well, and it has to be stable, and it has to have no wrinkles. So that is how a ideal LASIK flap should look like. And here, when they have measured, they have mentioned that the flap is actually 72 microns, which is actually acceptable. So as I told you, 100 microns is a maximum amount. So 72 is acceptable. So that's how you get to know whether the flap is normal and the stromal bed is normal, etc. So that's the utility of AS-OCT in case of LASIK. Next, we have Boston type 1 keratoprosthesis. I had told you I'll show you how a keratoprosthesis would look like. So this is how it would look like. So this is Boston type 1 keratoprosthesis, but there are also other types of keratoprosthesis like Osteo-Odonto-Keratoprosthesis, which I'll be showing in another slide. So here we have four portions: the front part, corneal graft, back plate, and a locking ring. So all this is clearly visualized in a AS-OCT. So basically, for what purpose we do AS-OCT in a keratoprosthesis patient is to find the interaction of that particular structure with other anterior segment structure. Like for example, if you can see, there is an iris backplate touch here. So this can lead to glaucoma, and it could lead to post-operative complications. So for that purpose, it is very necessary to measure it and analyze the structure post-surgical intervention. So this is basically done in case of chemical or thermal injury or even autoimmune conditions like Stevens-Johnson syndrome, or even when there is corneal blindness due to repeated corneal graft procedures. So now we have come to the third pole. So this is a case actually. So you have a 22-year-old female who prefers to have a refractive surgery done with a power of 18.5 diopters in a right eye. So, what would be your suggestion for the type of surgery that she should go ahead with?
Quite a mix between im- implantable columnar lens ICL and femtosecond LASIK. 48% want to go for ICL.
Mhm.
About 40% says they would probably recommend femtosecond LASIK, and 12% says mild refractive surgery.
Okay, so if I can tell you, femtosecond LASIK is actually capable of correcting only up to 14 diopters of myopia, and smile refractive surgery is actually capable of correcting up till 10 diopters of myopia, and maybe a spherical equivalent of 12.5 diopters of myopia. But implantable columnar lenses is the right answer, and it is capable of correcting up till 23 diopters of myopia, and that is the preferred procedure that we would be going ahead with the patient if they have a very high refractive surgery. Sorry, a very high refractive error. So So implantable columnar lenses are actually preferred for refractive corrections, and there are certain criteria which has to be maintained prior to performing the surgery for the patient. Like there should be a typical um, anterior chamber depth of about minimum of 2.8 mm in order to undergo the ICL procedure, and there should be some amount of minimal endothelial cell density as well, which is actually 2000 cells per millimeter square. There is a certain set standard for each age group, but specifically it is contraindicated when the patient has um, a cell density of less than 2000 cells per millimeter square. So, and as I already told, the depth has to be, anterior chamber depth has to be maintained at a minimum of 2.8 mm. So, this anterior chamber depth is actually going to be the distance between the corneal endothelium to the anterior surface of the crystalline lens. So this is very necessary because you have to measure whether there is going to be any rubbing of the ICL with the already existing crystalline lens. Because in those cases when there is rubbing, it could lead to cataract, and also sometimes there could be glaucoma in the upcoming days when there are very extreme complications happening. So there is also one more thing which is actually measured here. This is actually the central volt. So this is the distance between the back of the ICL, the posterior surface of the ICL, and the anterior crystalline lens pole. So this actually is the ICL which is placed, and this portion is the crystalline lens which is already existing. So this is the central volt which is being measured. So ideal volt which has to be present is around 250 to 750 microns. So when you have a volt which is less than 250 microns, there is ICL and lens interaction, as I told, and there would be cataract and other complications. So when it is excessive, that is when it is more than 750 microns, there would be glaucomatous complications in the patient. Next, we also have another option, which is Phakic IOL or the iris fixated IOL. So in that case, the IOL would be fixated on the iris, and here you can again see the iris fixated IOL, which is attached to the iris, and you also have the crystalline lens, which is being present. Here again, the anterior chamber depth has to be maintained, and it has to be measured prior to performing the procedure in order to have a healthy patient or a healthy um, cornea and a normal healthy subject. So because it can end up with glaucoma or even other complications in the long run. So next we are moving on to another condition where iris becomes adherent with the locomatous cornea. So if you can look at this portion, you can see that the iris is associated with the cornea. So this is where usually when there is a perforating corneal injury and it is a recovering cornea, the iris can get attached with the cornea. So in that cases, it is necessary to treat the adherent leukoma which is present. So this is actually the 4-quadrant image which I mentioned before. So this is how a 4-quadrant image would look like between 0 to 180 and different angles, degrees, etc. So next we are going to talk about certain corneal conditions. So the first one is ocular surface squamous neoplasia. So here you actually have an abrupt transition between the normal and the abnormal cornea. So ocular surface squamous neoplasia is the malignancy of the cornea as well as a conjunctiva, where there is abnormal tumorous growth of various squamous epithelial cells. So you should be able to see a thickened epithelium which is present, which is actually this, and you also have a lesion which is present, which is showing an abrupt transition between the normal and the abnormal one. So here you have the abrupt transition, and here you have the hyperreflective lesion which is actually present. So sometimes when these lesions are actually present, there would be increased um, obscuration, or there would be certain structures which are below this which will be invisible. So this would actually prevent the visibility of the other structures which are present below that. So that also happens sometimes. So in case of corneal condition as well as in case of conjunctival conditions. So here you have Salzmann nodular degeneration, which is actually a non-inflammatory condition. So here the epithelium appears completely normal, but the subepithelial location. So this is actually the epithelium. A is actually the epithelium, which is absolutely normal, but the subepithelium actually is hyperreflective, and there is also some materials which cause some conditions, viral condition which cause Salzmann nodular degeneration. Like basically when there is trachoma or scarlet fever or measles, or even in cases of vernal conjunctivitis, the patient might end up having Salzmann nodular degeneration, in which differential diagnosis can be made by using a AS-OCT technique, because sometimes when this patient would come to the clinic, they might end up thinking that this is actually an OSSN, which is ocular subsquamous neoplasia, and treat the patient for that. So in those conditions, if you look at the AS-OCT, you will be able to see that the epithelium is unaffected, but the subepithelium is actually showing the hyperreflectivity. So you can actually differentially diagnose the patient as to what exactly is the condition for the patient. So next we are actually moving on to conjunctival diagnostics. So I'll talk about these three very generally, and we'll go with glaucoma diagnostics. So first thing is pterygium or the pingicula. So this, you must be knowing that it is non-cancerous, but there is a triangular growth over the cornea which happens. So this is actually having a thickened, sometimes there might be a thickened epithelium, and it might be slightly hyperreflective. In this case, it is not hyperreflective, but the location where the actual growth is present will be extremely hyperreflective. And this growth location would be ideally between the Bowman's membrane and the epithelium. And there is shadowing, as I already spoke about the other structures below that not being visible. This is actually called shadowing, and you will not be able to visualize the structure which are actually below the lesion. So this occurs in case of pterygium, and also other conditions like melanoma and lymphoma. So here you have melanoma, but melanoma is actually a pigmented lesion where you will be actually seeing a mass. Like it won't be a specific layer, it would be a big mass which will obscure all the underlying structure, and there would be shadowing below the lesion which would be present. In case of conjunctival lymphoma, you have a normal epithelium, or sometimes it might be hyperreflective. Here it is actually a normal epithelium, but if you look at the actual affected portion, which is the lymphoma, the conjunctival lymphoma is actually present here, but it is actually surrounded by a hyperreflective location or a layer which is not an uninvolved tissue. So this hyperreflective location is actually uninvolved lesion, but this portion where it is medially hyporeflective is the affected lymphoma location. So the epithelium appears normal here, but sometimes it might also be hyporeflective. So this is about the various corneal conjunctival diagnostics using AS-OCT. And now we have come to the fourth pole. So this is actually something that I mentioned I will show in the upcoming slides. So what is a method of treatment in case of a severely diseased cornea with a chemical injury? And another information is it is bilateral. Okay, I can see that most of you have preferred amniotic membrane graft, but actually it is an Osteo-Odonto-Keratoprosthesis. So basically, you have two different types of Boston keratoprosthesis. The first one is actually the type 1 Boston keratoprosthesis, which I showed in the previous slides. This is actually done when sufficient wetting function is available in order to maintain the corneal tissue. But in cases where there is severe dry eye and there is minimal or no tear production, type 2 Boston keratoprosthesis is usually preferred, or the other one which is preferred is the osteo-odonto-keratoprosthesis. And in case of a chemical injury or a thermal burn, you obviously would expect there would be complete dry eye and there would be no tear production or minimal tear production in that case. So you would actually prefer going with osteo-odonto-keratoprosthesis in this case. So I will just show you an image how it's going to look in AS-OCT images. I'm not just going to go into details about the measuring ones, but this is how it would actually look in AS-OCT image. So next we are moving on to glaucoma diagnostics. So various parameters of the anterior chamber can be measured by using AS-OCT, like the angle opening distance and anterior chamber width, depth, and pupil diameter, as well as the anterior chamber the area as can be measured. And apart from that, you would also be able to visualize the anterior chamber post glaucoma surgery or in case of bleb assessment. And finally, you would actually use it for visualizing the shunts, which are uh, done in very extreme cases. So this is actually an image showing the various measurements which are actually done. So ACD actually represents the anterior chamber depth, and this is, as I already mentioned, the distance between the posterior surface of the cornea and the this surface of the crystalline anterior surface of the crystalline lens. Next thing is the pupil diameter, which is the distance between the two pupil extremes. And the next one is the anterior chamber width, which is actually the distance between the two scleral spurs. And you also have the lens volt, which is the perpendicular distance between the anterior pole of the crystalline lens and the horizontal line, which you actually measured for getting the anterior chamber width. So this is actually the lens volt. And you also have the anterior chamber area, which is the complete area which is bordered by the posterior surface of the cornea, the anterior surface of the iris, and also the anterior surface of the lens, which is located within the pupil. So this is what you would ideally measure in a glaucomatous patient or in even other conditions, like in case of a LASIK pre-LASIK patient, you would prefer measuring even the pupil diameter. So it's ideally used for many diagnostic steps, like for LASIK as well as for glaucoma. So this is the next pole. You can just take a guess how the angle and the anterior chamber is.
Quite difference in opinion again. There is 33% of the attendees who say it's open and shallow, whereas a contraindicting 33% says closed and shallow. So that's quite contradicting exactly the same number of people saying totally different things. And 19% of them say it's open and deep, whereas 16% of them say it's closed and deep.
So they answer is closed and shallow, because you can not view the angle at all, because almost the trabecular meshwork is not visible, and it's not possible to measure the angle here. So it is a closed as well as a shallow anterior chamber. So, so this is just to show you that an angle closure glaucoma could also be an open angle glaucoma sometimes. Like, because in case of cataract, after treating the cataract, post-operatively, the patient could turn into an open angle glaucoma. So it's very necessary to look at the cataract status of the patient before concluding whether it is an open angle glaucoma or a closed angle glaucoma. So this is showing the various anterior chamber depth in case of an open angle. In both these images, the angle is open. But the anterior chamber depth is different. So you can see that it is a very deep anterior chamber, but here it is a shallow anterior chamber. But both is open. But in the previous image which I showed in the pole, the angle was also closed and it was also a shallow anterior chamber. Here the angle is visible, how the angle is visible, and but the depth is also shallow. So next we have some closed angles, which is actually without peripheral anterior synechiae, but due to iridotrabecular apposition. So you have the iris here and you have the trabecular meshwork located somewhere here. So you have an apposition, that is the combination or attachment of the iris to the trabecular meshwork, which causes this closed angle. But there is no peripheral anterior synechiae. But if you look at this image, you can see that the peripheral iris is actually adhering to the angle as such. So there is no angle visible here. So this is where the peripheral iris is completely adhering to the angle. So there is peripheral anterior synechiae here. And this could be probably appearing in case of post-traumatic or even after cataract surgery, or when there is iris bombay, when there is a pupillary block glaucoma. So in case of pupillary block glaucoma, you would actually have the apposition of the iris to the lens. So you have the iris here and there is a lens here. Sometimes when the patient undergoes the cataract surgery, when they are pseudophakic or even if they are aphakic, there could be anterior vitreous displacement, due to which there would be attachment of the iris to the lens, which could cause pupillary block. So this is actually going to prevent the flow of aqueous from the posterior chamber to the anterior chamber. It ideally goes from the posterior chamber into the anterior chamber in order to drain into the trabecular meshwork. But when there is a pupillary block, that pathway is blocked and it is not possible to drain the aqueous humor, which will cause an increase in the intraocular pressure of the patient. So this is plateau iris configuration. Ideally, in a plateau iris configuration, you would have a normal anterior chamber depth, but the iris would assume a plane location or a plane shape. So it would appear very straight and it is not very curved or not convex or any position. So when there is a plateau iris mechanism, there could be associated pupillary block, and there would be glaucoma associated with it. As I already mentioned in the first slides, in order to diagnose plateau iris and pupillary block UVM is the gold standard technique, because it is also able to visualize the ciliary processes and the retroiridal processes. So ideally you would use a UVM, but it is also possible to visualize the structures by using an AS-OCT in order to confirm the diagnosis in certain cases when the patient is very uncooperative, or if the patient is a kid sometimes. So it's possible to use an AS-OCT compared to that of an UVM, because UVM is going to involve a very long procedure which needs cooperation from the patient. So it's useful to use the AS-OCT in such cases in order to make a diagnosis. So now coming on to the treatment in glaucoma. So you must be knowing that peripheral iridotomy is the laser procedure which is used to create an opening in the iris in order to allow drainage of aqueous humor to maintain the intraocular pressure. So if you can look here, there is a cut or there is a opening which is present, which is actually created due to the iridotomy procedure. And through this procedure, if you can see here, it appears as two different structures, but ideally speaking, this is a cross-sectional image. So you are not able to see the entire 360 degree. This is just a cross-sectional image. So through this way, it is able to reach the anterior portion of the uh, eye and drain out through the Schlemm's canal of the trabecular meshwork. So this is the peripheral iridotomy image in our AS-OCT. And you also can make bleb measurements, like because post I mentioned that post surgeries of the glaucoma patient, you will be able to analyze the anterior chamber and assess the angle opening of the patient. But even the morphology of the bleb can be investigated by using AS-OCT, like the dimensions, the length, and the breadth, etc., can be measured by using the AS-OCT technique. And we've come to the last poll and almost the end of the presentation. So, what is the treatment modality for patients who are not responding to maximal medical therapy and who also have failed filtering surgery? So, by filtering surgery, I mean trabeculectomy in case of glaucoma.
Yep, 50%, almost half of them think argon laser trabeculoplasty would be an option for this kind of patient. The rest, 33%, think valve implant, whereas 17% think sclerotomy.
So, in case of those patients who do not respond to any medical therapy, ideally we would go ahead with the valve implant because that would be the final way for treating the patient. So, valve implant is the answer. Trabeculoplasty is similar to trabeculectomy. So that is the primary line. When you prefer filtering surgeries, you can also consider trabeculoplasty. So that's not the treatment that they would go ahead with. So the answer is valve implant. Next, we have the image of Ahmed glaucoma valve and how it would appear in an AS-OCT image. So this will actually have a tube which is present, which allows the drainage of fluid from the posterior chamber to the anterior chamber. So this is how it would look in an AS-OCT image. So that's it for uh, for the various diagnosis of glaucoma. So I'd like to conclude that basically, when you are going to look at a patient, you can never diagnose it completely by using only an AS-OCT procedure. You have to combine it with other procedures as well, like you have to use a slit lamp, or you can use other techniques for looking at the patient and then diagnose it to be a particular ocular condition. But in some cases, there would be situations where you will have a dilemma whether it is one conjunctival condition or another corneal condition. So in that cases, you can actually make a differential diagnosis by using an AS-OCT. Apart from this, it is also used for various other purposes, like for dry eye it is used, and for it is used for many other ocular surface conditions, and for viewing the conjunctiva or the sclera, etc. So it's used for various other purposes, but I have not included many of them here. So these are the basic things. Like basically, when a patient enters your clinic, if they show you a report and you will have to diagnose it or look at it and get an idea about what exactly that is. This would be useful. So that's it for my presentation. So these are my major references that I have used, and these are my acknowledgements. I like to thank my alma mater, Elite School of Optometry and Shankar Nethralaya, through whom I actually have this much knowledge. And I'd like to thank Online Optom Learning Series and Mr. Fuch for giving me this opportunity to share my knowledge with an entire crowd. And he was very supportive and um, very quick in responding to all my queries and doubts. And apart from that, I'd like to acknowledge slidescarnival.com and presentationgo.com, from where I use my template for the presentation. So that's it. If you have any queries, you can contact me through the mail which is mentioned there. And I'm open to taking any questions, which is actually present in the chat box.
Great. Okay. Thank you, Sweta. I think wonderful presentation. Thank you for your kind words as well. And loads of information, loads of the ways how we can use anterior segment OCT in terms of ocular condition diagnosis. So that's a very important aspect. And you did mention a takeaway message that people may walk into our practices, as you know, we are doing primary eye care. People may walk in with reports, and you cannot be clueless on what's happening. You must know whether you have an OCT or not to perform a test. But at the end of the day, you must know how to interpret a test. That's very, very important. You did mention that you there are a lot of other uses of anterior segment OCT, and your focus for the session today was basically on the conditions only. You did mention dry eye, you did mention about ocular surface
Yeah,
conditions which could basically be used.
yeah,
Uh, right, yeah,
yeah,
so it's a very important tool, I guess, and anterior segment OCT, in terms of looking at the anterior segment much more in depth. Like as you showed your picture, some of the pictures were quite clear, where we could see, we could measure the depth of the tissue which needs to be removed when the ophthalmologist want to perform any kind of keratoplasty for that matter.
yeah,
So it's really an important tool, I guess, and I'm hoping that it is widely used, because I guess anterior segment OCT is not as famous or as widely used as posterior segment, or using an OCT for imaging for the posterior segment, right?
yeah. It's not as widely used as posterior segment OCT.
Yeah, it's quite less used these days. So the first question here is, it's more of a surgical aspect. I'm not too sure, but let's just see if you have any experience, because while you were performing some anterior segment OCTs, did you come across any patients who had graft rejection in terms of DSEC and DMEM patients? Any experience?
Okay. Yeah, yeah. I have few things to say on that. Like, ideally speaking, these two procedures, DSEK and DMEK, these two procedures have become the modern endothelial keratoplasty, because penetrating keratoplasty would end up with a graft rejection very soon. Like, most of the patient who go ahead with the PK might end up with having a graft rejection, or it might not be successful in most of the cases. But the modern endothelial keratoplasty techniques, which actually is DSEK and DMEK, are comparatively more successful. Like if I can mention, DMEK is actually 80%, is successful in almost 80% of the eyes. Like through literatures, I'm telling, like while I was reading, they have mentioned that DMEK is successful in almost 80% of the patient, and they acquire a visual acuity of around 6 by 9 post surgical procedure. Almost 80% of them reach that visual acuity. So that means it's really successful, right? So DMEK and DSEK, I think it is really successful compared to PK. And there would be possibilities of graft rejection in DSEK and DMEK as well, but that's not in our hands. Like we have to look at what is the post surgical status of the cornea in order to tell about or to comment about that.
That's true. That's true. Right. But I think our role is we can help to monitor, because graft rejection is something which I think can be picked up during follow-ups, right? So
Yeah,
anterior segment OCT can be a useful tool again to image it every time when the patient comes for a follow-up, and you probably can pick up that early graft rejection, and maybe you can save the complete graft rejection. I'm not too sure. This is more towards surgical, but it can help. I mean, we are looking at the usefulness of the instrument, and I guess it can be definitely be very useful.
yeah.
Okay, let's look at another question. I think you did mention this, but let's see. Can you also name some few anterior segment OCTs, if you have any experience with other than the one you have mentioned?
Mhm.
And does most of them require any special adapter lens accessory?
Okay. Like I mentioned about Z's and Cirrus. Yes, I mentioned about those. There is another one, Viscante OCT. That's a time domain based OCT. And there is also Heidelberg slit lamp OCT, which is also based on time domain OCT. And you also have Cassia, which is another type. And there are also ultra high resolution type OCTs. um, I'm not too sure if all of them use an adapter, but there is one such type of OCT which is actually capable of changing the type of location it images. Like there is a type of OCT which is actually imaging the posterior segment, but in that you would be using an adapter lens in order to change it for imaging the anterior segment. So in that case, I have heard of using an adapter lens, but I'm not too sure if all of the others, like the other OCT instruments that I've mentioned, use adapter lenses in order to acquire the image that they give.
Yeah.
Uh,
Okay, I think that answers that question very well. And what could be the reason for hyperreflectivity in both lesion and scar? Any comments on that? Because you did mention that when you're looking at the corneal tissue, the
mhm.
hyperreflectivity is what we need to look for. That's the
Yeah,
kind of thing which is abnormal. So, what do you think would be the reason of that being hyperreflective? Any comments on that?
yeah. So, in case of a scar or a lesion, the cornea is not as normal as it has to be. Like the normal function of the cornea is not maintained. So that means the stromal function, the endothelial function, the other normal biomechanical processes of the cornea is not maintained. So in that case, there would be some changes in the structures as well as the cells which are present. So basically, due to that, I assume that there is an hyperreflectivity. But whenever there is an hyperreflectivity, it is suspicious that it could be something. But it is necessary, to correlate it with a clinical picture and then conclude about what exactly that is. But hyperreflectivity as such basically represents that there is something wrong, because there is certain amount of reflectivity that has to be maintained. This is because like you actually measure the time delay and the difference, right? When you actually measure the um, images in the OCT instrument as such. So there is some amount of light which is going to the reference beam and some amount of light which is going to the sample. So when they return back, they do have some echo delays and there is some amount of intensity difference between them. So when you have a normal cornea, it would have some amount of particular intensity and a particular delay, or the echo delay or the time delay that it would possess. But in case of a scarred cornea, the time delay that it would take, or the intensity at which the light is going to get reflected back, is actually going to differ from what exactly a normal cornea would be sending back or reflecting back. So there would be a difference in the type of reflectivity pattern or the type of intensity that the light is going to be coming back. All that differs between a normal and an abnormal cornea. So based on that, uh, there is some hyperreflectivity, I assume. But
Yeah,
but I'm not sure about it. I can look at it why exactly it is happening and give you an answer, Chitra.
yeah. Uh, I also think is I had a different opinion. Maybe I'm wrong, but maybe because of the transparency of the cornea, because the cornea is not that transparent. I think the lag delay, what you mentioned,
Mm-hmm.
the delay in the time which the signals have been reached to the reference arm because of the corneal transparency. That's why the hyperreflectivity, because it takes larger time. Yeah, it
Yeah,
could be. I'm not sure also.
yeah,
Yeah.
probably that could also be the reason.
Okay, okay, no problem. So let's look at another question, a couple of more questions. Is there any complications for patients who had their valve implant? In terms of complications, I guess any experience, first of all, because probably in anterior segment OCT, have you come across any patients who you did see some complications which was detected during anterior segment OCT? Any
There
thoughts?
could be complications because the patient has already undergone a filtering surgery, and this is the other surgery which is being performed. One common complication that I have seen in the clinic is hypotony, and yeah, the cornea decompensates, and sometimes there is no other option or there is no other treatment that can be done further. That could be one such complication, but sometimes it's very successful and the IOP gets maintained, and they didn't, need not even take medications like the normal medicines which are given for the patient. So that could
Okay.
also be happening.
Great. Okay. Okay. One last question, which is, what do you think would be the surgical process? Again, this is more of ophthalmological. Sorry, I'm taking up this question, but I'm just looking for if you have any thoughts, if you have any experience, in seeing these kind of patients. What surgical procedures would you think be advised for patients who have completely covered, who has a complete stem blepharon, probably? Have you seen such kind of patients who may have visited for anterior segment OCTs?
Yeah, yeah. But um, you would actually give a contact lens, scleral type of contact lens. From an optometric point of view, um, I would suggest going ahead with a scleral contact lens in a symblepharon patient. But before fitting the patient with a scleral contact lens, there would be certain surgical procedures in order to release the symblepharon, and then we would go ahead with the scleral contact lens fitting. But if you look at surgical procedures, I think even amniotic membrane graft might be preferred. Um, and sometimes when there is, if the symblepharon and the dry eye which is present in the patient, if it is going to be due to Steven Johnson syndrome or any other syndrome in that patient, then probably keratoprosthesis would be ideal way for treating the patient. But basically, if the patient is developing symblepharon post usage of any ocular drugs, or the allergy that they develop due to the ocular drug which they have used, then you would go ahead with treating the patient using a scleral lens compared to any surgical procedure, because any time uh, anytime lens fitting is comparatively better than a surgical procedure. So in extreme cases, I think they would go ahead with any surgical procedures as I had mentioned.
Okay, great, great,
But
great.
the primary treatment would be contact lens.
Yeah, yeah, yep. So I think thank you, Sweta. I think we have taken almost all good questions. So quite a bit of surgical related questions, but I just took it up to just make sure that if you have any experience, we can get some knowledge out of it. And thank you very much for giving us your thoughts, giving us the ideas, and sharing the information today.
Yeah, sure. Thank you so much for this opportunity.
Most welcome, most welcome. So, just a reminder to everyone that we are having case presentation series. I think one of the case which you did hear yesterday on binocular vision using a computer-based therapy for amblyopia treatment. Such kind of cases, if you have any unique case, please go to our website and submit your abstracts, and we would schedule your presentation, and you can share and we all can learn together and discuss the case and get opinions from senior optometrists who join us onto this session and who have more experience probably in seeing somebody who has more experience in seeing that particular condition, so we can always learn together. So we do have sessions planned next weekend. Stay tuned. Stay safe until then. Take care, and I will see you all again next weekend. Bye bye.